Hello and welcome to the topic Superior Vena Cava Syndrome in the Haematology module. By the end of this topic, you should be able to define Superior Vena Cava Syndrome, explain the pathophysiology of the syndrome, outline the causes and classification of the syndrome, describe the clinical manifestations of Superior Vena Cava Syndrome, outline the investigations done, discuss the principles of management, and discuss the complications and prognosis of this condition. Let's get started. Superior Vena Cava Syndrome is the obstruction of blood flow through the superior vena cava. It is a medical emergency and most often manifests in patients with a malignant disease process within the thorax. The superior vena cava is the major drainage vessel from venous blood from the head, neck, upper extremities, and upper thorax. It is located at the middle mediastinum and is surrounded by relatively rigid structures such as the sternum, trachea, right bronchus, aorta, pulmonary artery, and the perihilar and paratracheal lymph nodes. It is a thin-walled, low-pressure vascular structure. This wall is easily compressed as it traverses the right side of the mediastinum. Obstruction of the SVC may be caused by neoplastic invasion of the venous wall associated with intravascular thrombosis, or more simply by extrinsic pressure of a tumor mass against the relatively thin-walled SVC. Complete SVC obstruction is the result of intravascular thrombosis in combination with extrinsic pressure. Incomplete SVC obstruction is more often secondary to extrinsic pressure without thrombosis. An obstructed SVC initiates collateral venous return to the heart from the upper half of the body through four principal pathways. The first and foremost important pathway is the exiguous venous system, which includes the exiguous vein, the hemiexiguous vein, and the connecting intercostal veins. The second pathway is the internal mammary venous system, plus tributaries and secondary communications to the superior and inferior epigastric vein. The long thoracic venous system, with its connections to the femoral veins and vertebral veins, provides the third and fourth collateral routes, respectively. Despite these collateral pathways, venous pressure is almost always elevated in the upper compartment if obstruction of the SVC is present. There are many factors that can cause superior vena cava syndrome. The causes can be classified into malignant conditions and non-malignant conditions. Malignant conditions consist more than 80% of superior vena cava syndrome. The examples are bronchogenic carcinoma, which most of these being small cell carcinomas, non-Hodgkin's lymphoma, especially the large cell type, Hodgkin's disease, metastatic cancers, primary leiomyosarcomas of the mediastinal vessels, and plasmacytomas. Non-malignant conditions contribute approximately 20% of cases of SVCs. The examples are mediastinal fibrosis, vascular diseases such as aortic aneurysms, vasculitis, and arteriovenous fistulas, infections such as histoplasmosis, tuberculosis, syphilis, and actinomycosis, benign mediastinal tumors such as teratoma, cystic hygroma, thymoma, and dermoid cyst, cardiac causes such as pericarditis and atrial myxoma, and thrombosis related to the presence of central vein catheters. This table shows the benign and malignant causes of SVC's obstruction. The classification is based on radiographic evidences and clinical manifestations of the syndrome. This table depicts the grading of superior vena cava obstruction. Grade 0 is asymptomatic, grade 1 is mild, where there would be edema of the head, neck, cyanosis, and plethora. Grade 2 is moderate, where there would be edema of the head or neck with functional impairment. Grade 3 is severe, mild to moderate cerebral edema or mild to moderate laryngeal edema or diminished cardiac reserve. Grade 4 is life-threatening, where there's substantial cerebral edema or laryngeal edema or hemodynamic compromise. And grade 5 is fatal, where there can be death. Now, let's discuss the clinical manifestations of SVC syndrome. The symptoms of this syndrome include shortness of breath, facial swelling, head fullness, coughing, arm swelling, chest pain, distorted vision, hoarseness of voice, headache, nasal stuffiness, nausea, and lightheadedness. Bending forward or lying down may aggravate the symptoms and signs. The signs of SVC syndrome are dysphagia, orthopnea, stridor, pleural effusions, venous distension of the neck and chest wall, facial edema, upper extremity edema, mental changes, plethora, cyanosis, papilloedema, stupor, and coma. This table depicts the presenting symptoms in SVC syndrome, which are common and also less common ones, which could take place in severe or higher gradings. SVC syndrome is a clinical diagnosis. However, imaging such as plain radiography, CT, and venography are used for confirmation. So, chest X-ray may reveal a widened mediastinum or a mass in the right side of the chest. Computed tomography has the advantage of providing more accurate information on the location of the obstruction and may guide attempts at biopsy by mediastinoscopy, bronchoscopy, or percutaneous fine needle aspiration. A CT scan of the chest is the initial test of choice to determine whether an obstruction is due to external compression or due to thrombosis, and sputum cytologic results are diagnostic in 68% of cases. Biopsy of a palpable supraclavicular node is positive in 87% of cases. Thus, radiological grading of SVC syndrome, and this to provide information about the prognosis. So, as we noticed, grade 0 is narrowing without clinical evidence of SVC syndrome. Grade 1 has two subgrades, which is 1A and 1B. 1A is mild SVC narrowing without collaterals, while 1B indicates moderate SVC narrowing without collaterals. Grade 2 is when severe SVC narrowing occurs above the azygos, with the azygos vein serving as partial collateral. And grade 3 is SVC obstruction below the azygos arch, while grade 4 is SVC obstruction at the azygos arch. In the management of superior vena cava syndrome, the goals are to relieve symptoms and to attempt cure of the primary malignant process. Only a small percentage of patients with rapid onset obstruction of the superior vena cava are at risk of life-threatening complications. Patients with clinical SVC syndrome often gain significant symptomatic improvement for conservative treatment measures including elevation of the head of the bed and supplemental oxygen. Emergency treatment is indicated when brain edema, decreased cardiac output, or upper airway edema is present. Corticosteroids and diuretics are often used to relieve laryngeal or cerebral edema. Radiotherapy has been advocated as a standard treatment for most patients with SVC syndrome. It is used as the initial treatment if a histologic diagnosis cannot be established and the clinical status of the patient is deteriorating. Chemotherapy may be a preferable option to radiation for patients with chemosensitive tumors. When superior vena cava syndrome is due to thrombus around the central venous catheter, patients may be treated with thrombolytics and anticoagulants. Surgical procedures are done to improve and relieve the symptoms. Surgical bypass of the superior vena cava may be a useful way to palliate symptoms. Indications for proceeding with such procedures are not fully clear. For the most part, these are patients with advanced intrathoracic disease amenable only to palliative therapy. The principal options for endovascular therapy today are stenting, percutaneous transluminal angioplasty, thrombolysis, or some combination thereof. In most patients with SVCs, stenting of the SVC provides rapid symptomatic relief within few days. Now, these are the diagnostic steps that one can take in order to diagnose as well as to manage in the early stage, and if there's no success, to the late stage, which is palliative guided. Complications of SVCs include laryngeal edema, cerebral edema, decreased cardiac output with hypotension, and pulmonary embolism when an associated thrombus is present. Survival in patients with SVC syndrome depend mainly on the cause of the underlying disease. No mortality per se results directly from mild venous congestion. Patients with signs and symptoms of laryngeal edema and cerebral edema have the most life-threatening manifestations of superior vena cava syndrome and are in danger of sudden death. Patients with untreated malignant superior vena cava syndrome survive for only 30 days. Survival for those who do not respond to treatment is similar. In patients with benign superior vena cava syndrome, life expectancy is unchanged. If this condition is secondary to a malignant process, survival correlates with tumor histology. In summary, superior vena cava syndrome is the obstruction of blood flow through the superior vena cava. Obstruction of the superior vena cava may be caused by neoplastic invasion of the venous wall associated with intravascular thrombosis, or more simply by extrinsic pressure of a tumor mass against the relatively thinned wall superior vena cava. The causes of superior vena cava syndrome can be classified into malignant conditions, which is the most common, and non-malignant conditions. Clinical manifestations of superior vena cava syndrome are dysphagia, orthopnea, stridor, pleural effusion, venous distension of the neck and chest wall, facial edema, upper extremity edema, mental changes, plethora, cyanosis, papilloedema, and coma. Imaging studies to evaluate superior vena cava syndrome are chest X-ray and CT scans. In the management of this syndrome, the goals are to relieve symptoms and to attempt cure of the primary malignant process. Only a small percentage of patients with rapid onset of the superior vena cava obstruction are at risk of life-threatening complications. We have come to the end of this topic. Thank you.